Welcome back for another round of Hormones Part 3. Of course, I'm with my guest host here for the third week in a row, Dr. Megan Strauchman. Thank you for coming back.
Thanks for having me.
So just to catch everybody up to speed who hasn't watched in the last 2 weeks, we're doing a 3-part series on hormones. So week 1, we really sort of looked more at hormones in a functional sense, meaning what do each of the various hormones do, how those hormones interplay with adolescent idiopathic scoliosis, especially in the teenage years. What roles do they play? Why do they have any relevance to scoliosis management? Last week, we went more into the adult side of things, how hormone problems interplay with menopause and interplay with bone density issues and things like that. This week, I wanted to kind of finish this off with, so we have a hormone problem. I'm an adult patient or I'm a teenage patient. What am I going to do about it? Because obviously we want to treat those things. Now, that said, I think to sort of start this off with a perspective of treating teenagers, I think Dr. Strauchman would agree that the last thing that I want to do, or that anybody really wants to do, is to give a teenager hormones. I would much rather, especially from an integrative holistic perspective, I would rather give that patient, whether it be enzymes or precursors or whatever, amino acids, whatever it is, to encourage normal hormone output as much as possible before ever resorting to giving a teenager a hormone.
I agree.
Agreed?
Yeah, definitely.
Right, perfect. So I would like to so examples of that are going to be things like over-the-counter pregnenolone, over-the-counter DHEA, dietary modifications or lifestyle modifications. For example, minimizing exposures to environmental sources of what we call xenoestrogens, estrogen mimicking chemicals in plastics and other terrible sources, right? So I think all of those kinds of recommendations are good for teenagers, in any combination of those, depending on what their hormone laboratory results look like. But for adults, it's a little bit different scenario. It's a little bit more involved. Because obviously, especially in females, but it's everybody, but particularly in females within the confines of scoliosis management, since it is a female-dominated condition historically, one of the big issues is perimenopause. And the reason being, of course, like we touched on last week, we have hormone issues that lead to bone density issues that then lead to existing curve progression issues, or in some cases, what they call de novo onset of scoliosis, for what they term degenerative lumbar scoliosis, which occurs in almost 2 out of 3 women over age 60. And what's the commonality? Hormone changes. Well, one of the things Dr. Strauchman always alludes to is the idea that we age and our body basically goes to pot because our hormones decline. And our hormones decline for a bunch of environmental reasons. So one of the big things I felt like it would be imperative to touch on today, especially when talking about adult patient populations with scoliosis and hormone treatment, is the idea of hormone replacement therapy. And I have a bunch of data that I brought with us as well, but I'm going to have Dr. Strauchman kind of touch on hormone replacement therapy from a sense of what she does in her practice, how she kind of goes about figuring out hormones for patients on a individual basis. And then I'm going to kind of merge her expertise into what we find the data says and what some of the official position narratives are and things like that. And I might get a little bit conspiracy theory here on you, but follow me through the end and you'll understand why. So, Dr. Strauchman, talk to me about the difference between, for example, conventional hormone replacement therapy, which many women are rightfully afraid of, and contrast that to bioidentical hormone replacement therapy.
So I'm going to give you a history lesson. Back in the earlier part of the 1900s, the medical community felt that there must be ways to help women who are going through menopause. As we talked about in the previous podcast, these poor women, some of them were in such miserable ways during menopause that they went so far as to having to institutionalize some of them, which is horrid. So they started trying to find a way to replace these women's hormones and to make them feel better. Well, what they found was they were able to um, extract hormones from different things like soy and sweet yams. And the problem was when they did that and then tried to get a patent on it, you can't patent things that occur in nature, right? If it's natural, as
Correct.
you can imagine, how could you patent that? It already occurs. So therefore, they weren't able to receive a patent for hormones, even though they knew they worked. And they basically shelved them and returned to them several years later, altering them with what's called a methyl group, carbon and 3 hydrogens, for those of you who are bored and or late chemistry. And by doing so, they were able to alter the hormones, but they never tested them to see if that methyl group caused any type of issue. So what we have found in those years, so they made it, that is a synthetic hormone, right? It is a hormone that was natural. They altered it to make it patentable, therefore to be able to make more money off of it, right? That's what happens when you get a patent on something, you can make more money on it.
Sure.
And so they received their patent, they never tested it for safety, and they put it off into the community for people to take. And what we have found in the year since that occurred is that methyl group does cause issues. It causes inflammation, which can lead to an increased risk of blood clots. And problem being that I guess in my mind, knowing that you have the option to take bioidenticals, because that's what I use. I use bioidenticals in my practice, only bioidenticals. Knowing that you have that as an option, but letting someone convince you that taking something synthetic is a better idea, it just blows my mind. Why on earth would you want to take something that is not identical to what your body once made?
Sure. Well, speaking to that, so for the people who are listening or watching that don't know, what is an example of conventional hormone replacement in terms of the actual medicine itself? Like Premarin or Prempro? Like, what are they?
They're hormones with a methyl group attached to them.
Well, what about the concentration of them relative? So, for example...
They come in set doses, so they aren't... I can't change them to fit the patient. You have to, like any type of medication, if you took an antibiotic or whatnot, unless you're in the hospital and we're putting it into an IV bag and we can titrate it to your weight, they're made in different doses and you can't modify them. You can only prescribe the doses that are made.
That's a key point, because I'm going to kind of explain with some of the data here why doctors get hung up on bioidentical hormone replacement versus conventional hormone replacement is because of the lack of personalization, or maybe a better way to say it is due to that lack of personalization. It's actually a better fit for most doctors' insurance models of practice, where a doctor doesn't have time. If I want to go in, if I'm a patient and I want to go in and talk to my doctor about bioidenticals are something that really have to be personalized and take a lot of information and extrapolation of data and feedback from the patient to know how to really dial in their doses. Fair for bioidenticals?
Yeah, and there's other issues that exist, such as a lot of OBs I've noticed are still under the delusion that if a woman doesn't have a uterus, she doesn't need progesterone. That's something that I was taught 20 whatever years ago, and it's false. Progesterone is important for a woman whether she has a uterus or not. You have receptors for progesterone throughout your body, not just in your uterus. So
for sure,
a lot of women who tried the synthetic route and then come to me are always confused at first because they're so used to being told that progesterone is unnecessary for them because they don't have a uterus anymore.
Got it. So talk to me a little bit. So a lot of people have used conventional hormone replacement up until 2002, when a study was published called the Women's Health Initiative. And explain what that study was.
So that was what I was alluding to before, where I said that they gave women synthetic hormones for decades before saying, you know what, we should not probably continue to give these until we've tested them. And so they went through and they did a huge study. They had large cohort. It was, I want to say it was almost, wasn't it upwards of 1 million women? There was a lot of women in the
It was a lot of women.
The study. They discontinued the study though because they found that there was such a rise in blood clots leading to heart attack and stroke, an increase in endometrial cancer, and an increase in breast cancer.
And venous embolism, which you mentioned, and stroke.
Blood clots, yes.
And that's from using Prempro, particularly. So conventional hormone replacement.
Right. So problem being, and this is actually an issue that goes to just last week, where now they've come out and said, oh, never mind. Those studies they weren't good studies, and you shouldn't listen to those, and, it's all fine again. I struggle greatly with that because at the end of the day, this shouldn't even be debatable. We have bioidentical hormones. They're identical to what your body once made. We know they're better. We know they're readily available. Whatever your body made, it's like trying to compare breast milk to a formula in a can. Are you trying to tell me that what your body makes is not better for a baby than something that is in a can on a shelf in a grocery store? Sure. I mean, it boggles my mind that women get bamboozled into being told that, oh, no, these things that Big Pharma made you are fine. Just go take those. They're great. Take those. Instead of something that I can make you that came from plant sources that are molecularly identical to what your body once made.
For sure.
It boggles my mind. And I think if more women were educated, a lot of women don't want to be troubled by it, and they just want to feel better, and they just want their doctor to tell them what to take. And for that, they just go with it. Oh, well, my doctor said I should take this, and so I'm going to. It's just not, it's not right. It just shocks me. Look into it further.
Well, so to give you some timelines here. So a lot of the data that I have, there's only actually a few recent studies, and by recent I mean to say within the last 5 years, on anything related to bioidentical hormones. A lot of the data that I'm going to share with you today was published actually in the early 2000s up through the 2010s, since the Women's Health Initiative was published. Well, once the Women's Health Initiative was published, there was a dramatic decrease in the amount of utilization of conventional hormone replacement among traditional physicians. Understandably, I don't want to give my patient a blood clot or a stroke or breast cancer or endometrial cancer, blah, blah, blah. Well, obviously, as Dr. Strauchman's alluding to, bioidentical hormones are dramatically different, not just in the molecular structure of them, but in also how they're dosed, which is incredibly important. People don't recognize that the term Premarin, one of the conventional hormone replacement therapy options, stands for pregnant mare urine. And the problem is you get doses of hormones that are not necessarily suited for a 5'2", 110-pound female. They might be something that initially was produced by a horse that weighs 400 pounds, 700 pounds. And so it's not surprising that conventional hormone replacement caused the problems that it did. Well, we had a dramatic drop in the U.S. of conventional hormone utilization and a substantial rise in the mid-2000s, early 2010s in the use of bioidentical hormone replacement. And here's why. For example, in a survey, this was published in 2017 in the journal BMC, Biomed Central Women's Health. Women went towards bioidentical hormone replacement from conventional hormone replacement for, one, fear or uncertainty about the safety of regular hormone replacement therapy, two, an aversion to conjugated estrogens in particular, especially oral estrogens, and three, an overarching, and to me this is the funniest one, an overarching distrust of a medical system perceived as dismissive of their concerns and overly reliant on pharmaceuticals. Now, participants in the survey also voiced dissatisfaction with the effectiveness of herbal and soy supplements, and this is in regards to ameliorating their symptoms. Participants were attracted to bioidentical hormone replacement because they perceived it to be 1, effective in managing their symptoms. Imagine that. 2, safer than conventional hormone replacement therapy. Imagine that. And 3, tailored to their individual bodies and needs. And 4, accompanied by enhanced clinical care and attention. Well, everybody that I know, and I'm sure that Dr. Strauchman knows, that does bioidentical hormone replacement therapy, like her, you know what she does is she sits down with people. She gets to know everything about that patient. This isn't something where she's in and out of the room in 7 minutes because that's what your insurance dictates, because she's got to go see another 300 people over the next 5 hours. This is a type of care structure where you have to treat the whole person. You have to be thorough. Am I right?
Yes. And you have to remember, too, that, again, when I get women who have been on synthetics, they oftentimes don't have testosterone replacement, which as I've often said to you, your hormones are a symphony, not a solo. So you should make sure that you replace
I've heard that more than once on this
symphony.
podcast.
They're a symphony, not a solo. So you have to replace your testosterone too.
And not surprisingly, so the North American Menopause Society reported in 2021 that since the Women's Health Initiative study was published, 40% of menopause patients are using bioidentical hormones. Well, now I'm going to give you the politics of medicine, right? So then, because we start cutting into the profits of companies that make conventional hormone replacement therapy, we sick the political professional dogs on bioidentical hormones, to the point where now the North American Menopause Society and the American College of Obstetricians and Gynecologists each come out with their own position statements that basically say bioidenticals are bad and that hormone replacement really is okay. That it's really unfounded that you should be afraid of getting a blood clot or getting breast cancer. No. For example, North American Menopause Society 2017, prescribers should only consider compounded bioidenticals if women cannot tolerate a government-approved therapy for reasons such as allergies to ingredients. Well, guess what? A lot of people have allergies. That's actually quite common. She'll tell you that, right? Medications have to be compounded routinely because people have allergies to certain additives or ingredients in a medicine. That's happens all the time. Compounded bioidentical hormones present safety concerns such as minimal government regulation and monitoring, as if that is a guarantee, right? For example, think about this.
Hogwash.
Think about this. Every single medicine that has ever been pulled off of a pharmacy shelf or recalled by the FDA was first approved as safe by the FDA. Remember that.
You're fired up today.
I am fired up today.
And, here's the thing about it, too. And this is what's always bothered me about that statement. They're quite literally putting down pharmacists, people who went to pharmacy school. They have the same degree as the person at the Rite Aid Rite Aid doesn't exist, but the person at the Walgreens or whatever. Right. They have the same degree as them, but their job is that much more difficult because they have to take out, these specific, powders that are, by the way, they didn't go off and, farm the sweet yams themselves. These came from PCCA, which you guys can look up. It's a professional compounding pharmacy association, and they get all of this, and it is all verified and and checked and batch checked and whatnot. And then the pharmacist has to go through and make sure that the dosing's proper. And I'm very particular about my pharmacies. My pharmacies are very reputable, but compounding pharmacies, oftentimes the good ones, they send out to make sure that when they make up their specific compounds, they send them off to a third party to check them to make sure dosing is proper. They have to have all their equipment calibrated regularly. it's insulting to them, really, to treat them like that. I mean, these people are doing an incredible job in, saying, oh, because it wasn't made, by the way, most pharmaceuticals are not made in the United States. Compounding hormones are, to say that, oh, because this compounding pharmacist made it, it must not be good. And it's funny we're talking about this because I was thinking about it this morning, about how frustrating that is to me, how insulting that is to a compounding pharmacist, because they're sitting there, using all of the equipment and all the things they were taught in school, having these machines calibrated and taken care of, and all this stuff to make these compounded, different prescriptions, not just hormones, for these patients. And other docs and ACOG and whatever come out and say, oh no, these aren't regular big pharma meds, so they're not as safe.
Right.
Big pharma meds half the time, like
trust us, don't listen to this data.
They're not made in the United States. And then they recall them and say, oh, oops, we're sorry. We got something in them on accident that could cause cancer. How many times they've been recalled for that?
Right. For sure.
I mean, Kosar was recalled 5-6 years ago because there was something in it that was
Bextra,
not supposed to be in it that caused cancer.
All kinds. So that was North American Menopause Society's statement against bioidentical hormones. The American College, now I'm gonna square this circle for you here, right? The American College of Obstetricians and Gynecologists comes out and says, and this is their clinical consensus statement, clinicians should counsel patients that FDA-approved menopausal hormone therapies are recommended for the management of menopausal symptoms over compounded bioidentical hormones. If a patient requests the use of compounded bioidentical hormones, the doctor should educate them on the lack of FDA approval on these preparations. Okay, so let me square this circle for you. Let's go back to the Women's Health Initiative. They were testing conventional hormone replacement therapy, namely Prempro, Premarin. Okay? Now, who makes Prempro and Premarin? Pfizer. Okay? Now, let me ask you this. Of the top 5 corporate sponsors of the American College of Obstetricians and Gynecologists, guess who the top 3 are? Drug companies, one of which is Pfizer. You get where I'm going with this? At some point, modern medicine and their professional societies have become a cartel. And they become nothing more than, my opinion is out and available for the highest bidder. Give me enough money and I'll publish whatever you want me to publish. And that's a fact. It's an absolute fact.
You are truly fired up today.
I'm truly fired up today.
But he's
because
right.
This is
he's
bunk.
Not wrong.
This is bunk.
He is not wrong. Well, it's the truth. I mean, if you look at, we call it the Green Journal. It's ACOG's main medical journal that physicians read. It's all the advertisements in it are big pharma. I mean, how on earth are you supposed to take anything serious when that's where all the money rolls in from?
Now, this isn't old. This is ACOG, American College of Obstetricians and Gynecologists. They put this position statement out in 2023, so only 2 years ago. That's their position. Then in 2017, this is over in Europe, but again, wide rejection of conventional hormone replacement after the initial publication of the Women's Health Initiative led to unjustified use of custom compounded bioidenticals. What woman wants to have breast cancer, wants to have blood clots, wants to have endometrial cancer, wants to have stroke? None that I know of, right? So of course they want to seek something besides conventional hormone replacement. Author goes on, custom compounding is only seldom legitimate. For example, in cases of allergies such as to peanut oil. Well, as we said, that happens more than you think. Or to prescribe different combinations, doses, or components. So let me get this straight. This doctor actually thinks it's bad to prescribe an individualized dose of hormone for an individual person based on their individual needs. Think about that. I don't want to have to think, is what this doctor's saying. I just want to prescribe a set dose of hormone if somebody tells me they want hormone. I might be giving them way too much. I might not be giving them enough. And I have no means of dialing that up or down. With bioidenticals, you can hone that, and she'll tell you, you can hone that right in to that particular patient in front of you based on their needs and their symptoms, right?
Correct.
All right. Then 2021, and this is actually somebody, and this is, let me go back to the author here because I love this paper. This is in the journal Healthcare, published by Dr. Gary Donovitz of the Department of Obstetrics and Gynecology at the Morehouse School of Medicine in Atlanta. And he's the one actually refuting these society guidelines. And he goes on and says, the statement from ACOG that, quote, evidence lacking to support superiority claims of compounded bioidenticals over conventional menopausal hormone therapy is unfounded and outdated based on multiple studies. The non-oral administration of estradiol does not, as they try to claim, increase the risk of blood clots, whereas Prempro does increase the risk of blood clots. So there are studies that actually refute what ACOG is saying about the risk of blood clots from bioidenticals. Moreover, a landmark finding is that bioidentical testosterone with and without bioidentical estradiol can significantly reduce the risk of breast cancer. Both of these studies have the additional benefit of long-term safety data over 10 years. So everything these societies tell you, and this is the problem in medicine, is that professional society or societies have become like groupthink. Don't read the information for yourself. Don't bother to read the research for yourself. We'll just tell you what to think. But trust us, we're the experts. But what they're not telling you is they sold their opinion, their expert opinion, to the highest bidder. In this case, Pfizer. So bioidentical hormones are something very powerful as a tool for integrative physicians like Dr. Strauchman and a host of others across the world. And I encourage you, if you're somebody who needs to have a problem resolved or improved because it's a hormone-based problem, bioidenticals are something that I believe you should look into. And that's something we can help you here with at our office. Obviously, that's her department, not mine. But we have a great many adult scoliosis patients who do bioidenticals. Even if it's not from us, they have somebody locally that I kind of co-manage with to properly manage their bioidentical hormone doses properly, because it makes a world of difference. Not only in just terms of how they feel day to day, but again, to kind of bring this back into scoliosis, I'm worried about how does hormone decline affect bone density? How does hormone decline affect, like Dr. Strauchman just mentioned a little bit ago, progesterone receptors occur all over the body, and they're very prevalent in the brain. And one of the chief functions of progesterone in the brain is the maintenance of postural muscle memory. Well, if I'm trying to change somebody's scoliosis via doing some type of scoliosis-specific exercise therapy, or they're wearing a scoliosis activity suit, or maybe a combination of those, if I don't fix some of those underlying hormone problems, the benefits that they would otherwise get from the suit or the exercises are going to be somewhat sabotaged, or at worst might not be maintained over a long term if they ever decide to not do those exercises anymore or continue to wear the activity suit. So bioidenticals are a huge thing. So what I would like you to do, Doc, is to just kind of explain, so people get an idea on a day-to-day clinical basis. If somebody wanted to come in and see you as an example, because obviously you can only speak for you, but to just kind of go through in a general 50,000 foot overview and explain how you go about prescribing bioidenticals for a patient. Like, what's your process in general?
So when I originally see them, I go over all their symptoms. There's very standard common symptoms that you see, and then there's some outliers. Hot flashes, night sweats, loss of lean body mass, insomnia, whether they can't fall asleep or can't stay asleep, vaginal dryness, low libido. There's a lot of things. There's outliers like pain, joint pain, dry mouth. There's some other things that are outliers. But anyways, we go over all their symptomatology, and then I do a serum blood test when they're older like that. When they get older, salivary testing is not really as necessary. They're so low, you can see their numbers in their serum usually. And so we'll get their DHEA levels and if we're not sure if they're in menopause or not, we'll do an FSH and an LH, but we'll get their blood levels of hormones done. And then when those come back in, we sit down and we talk and we go over it and we get them prescribed.
So this is something, obviously, you would agree that this is a little bit more like an art form versus just
yes,
you have hot flashes, so I'm going to give you X hormone.
Yes. And I get patients who come from other doctors who didn't, I could tell, unfortunately, know what they were doing. They're just trying. They're trying to help, but they're probably making a bigger mess because they're on outrageous doses or a lack of dose or whatnot. So they'll be on the absolutely wrong dose, and all they ever did was keep bumping them up, or they didn't teach them to do hormone holidays, which is when you take 1 day off a week on your hormones. I don't do it right away. It depends on the patient. We wait to do it. We want to get their hormone receptors a little saturated first, but we start them on hormone holidays because that's kind of a long story, but you have to do that in order to make sure they don't get symptomatology back. And you retest. I clinically go by how they're feeling, and then I'll retest them. Blood work later on.
So could you touch on then a few of as far as like routes of administration, like what's the difference between taking and maybe why it's not good to take certain routes of administration of hormones?
You're not supposed to take estrogen or testosterone orally. Oral estrogen will increase your risk of blood clots, and oral testosterone increases glucose levels. So those are both done transdermally, and it's better that way. Put them in cream, and you apply the cream to some different areas of the body. The progesterone, you can give progesterone topically. The problem with topical progesterone is it's not as helpful with sleep, so I tend to give it orally. You can give it orally in a few different ways, but honestly, 20 years of doing this, I've always come back to doing capsules because it's just the easiest and the best way to give it, considering just some of the other shortcomings you have with dosing in other ways. And yeah, so cream for estrogen, testosterone, and capsule for progesterone mostly.
All right. To switch it over briefly to male patients.
Yes, that's in females, not
yes,
males.
Right. Yes, everything she was describing is more geared toward a female patient, which of course, again, from a scoliosis context is obviously, relevant. But speak to me for testosterone replacement in males. What's your...
So testosterone replacement in males, same idea about coming in, giving me their different types of symptomatology and their different issues, and then testing them, seeing what's going on, where their levels are at. I do a PSA and a CBC and some other chemistry levels to see where those are at too, to make sure that if they need testosterone replacement, that you don't have huge alterations in those levels. What can happen is sometimes their RBC, their hemoglobin hematocrit can go up. So you have to follow that and be careful with testosterone. Their PSA can go up too. And then testosterone in a male is usually best done injectable. I've tried cream through the years over and over again, but because some men have wanted to do it that way, they're scared of needles.
Well, one of the other things I've noticed, I don't know if you have ever run into this, is when we've had, and I noticed this actually quite by accident in a female teenager scoliosis patient, is we did hormone testing on her, and her salivary testosterone came back through the roof. And long story short, what we ended up finding out is dad had been taking for a number of years topical testosterone cream.
Yeah.
Well, what happens is that stuff gets into the bed sheets, it gets into the clothing, and guess what? Everybody's clothing gets laundered together. And so now you get that hormone in the whole family. And now everybody's bench pressing cars and growing mustaches.
Here's the problem too with men. And sorry to knock on men, I just see it more often because I actually had that case where a man who was on the topical transferred it to his wife because they used The only thing we could think of is they work out on the same elliptical every morning, and he put his cream on in the morning, which didn't make sense. He shouldn't have been putting on before he got on his elliptical, but whatever. Anyways, that's another problem. But he was putting his cream on and not washing his hands, and then he was using the elliptical, and they were both touching the elliptical.
And they were both bench pressing cars.
It's the only thing I could think of. It's the only thing we could figure out, because he actually did his own laundry. But when it comes to topicals with men, their dose of testosterone is so much higher than women. You have to put it in tons of cream. It's gobby and goopy, and it's too much. And so it's really just better injected. It really is. And plus...
Or pellets.
Sometimes. Men, when it comes to men, the injectables, you also have to dose them properly. I don't like this whole put in a huge bolus of testosterone and then let them ride it out for 2 weeks and then inject them again, because they end up doing this. And it's just this horrible peak and trough constantly, and nobody wants to feel like that.
Sure.
So if you dose them with smaller doses more frequently, and it's not a very big needle, you're fine. You dose them that way, it's just a better outcome. They don't have all those huge, fluxes in their testosterone levels. I hate that.
Got it.
It's not like your testicles emit every 2 weeks.
Right. Fair enough.
So
you do multiple days a week dosing for injections?
Sometimes 3. Usually I start with 2. And then depending on their age and their needs, sometimes we'll go to 3.
Got it.
Yeah.
And of course, men do get scoliosis too, and testosterone is very important at retaining lean muscle mass. Also important for bone density, which is why also many women have to take testosterone. But also testosterone and estrogen need to exist in balance in both men and women, just in different proportions. Because like she said, hormones are a symphony, not a solo act. Probably the take-home message of all this, I suppose. And not to mention, you know what? Do your own research. Any society out there that comes out with any kind of a position statement on something, don't listen to it. That opinion was bought and paid for by somebody, right? Do your own research on it. There's plenty of information on bioidenticals available online on PubMed. These are all PubMed journals that I pulled these from. It's not like somebody can say, oh, that's just Dr. Google. No. These are PubMed medical journals that I pulled this data from. So go read it for yourself. Anyhow, thank you for watching part 3 today. If you like what you've seen, especially over this 3-part hormone series, please like and subscribe to the Back Genius channel here on YouTube. And I would also especially like to thank our special guest for the last 3 weeks, my beautiful bride, Dr. Megan Strauchman. Thank you. You're so awesome.
You're very welcome.
I'm sure we will have her on again, because they always seem to be our more popular shows whenever she's on. So if you have any questions, you're always welcome to email us here at our local office, info@nwprc.com. You can also reach out to me, upload your x-rays for a free scoliosis consult at scoliosispractice.com. And for more information, you can always reach out to backgenius.com. However you want to reach out. We're available multiple ways. So for this week, thank you. Thank you for tuning in. We'll see you next week. Take care.